Good morning, good afternoon, good evening. I'd like to welcome you wherever you're listening to this Thoracic Oncology Group of Australasia podcast, where today we'll be discussing the multidisciplinary management of CNS metastases in the setting of thoracic cancers. I'd like to acknowledge the Indigenous peoples of both Australia and New Zealand, who are the traditional owners of the lands on which we live and work. I'd also like to thank Pfizer, who are the sponsors of this episode. I'm Adjunct Associate Professor Tim Clay. I'm a medical oncologist practicing at St John of God, Subiaco and Icon Cancer Care in Western Australia. And I'm delighted to be joined tonight by my co-discussants, Dr. Keryn Davidson. Dr. Davidson is a consultant neurosurgeon at Royal North Shore Hospital and North Shore Private Hospital in New South Wales. She's a graduate of the University of Queensland and undertook her training and fellowships both in New South Wales and in South Australia. And she has a significant caseload in the management of primary and secondary malignant disease of the CNS. Along with that, I'd like to welcome Associate Professor Fiona Hegi Johnson, who is well known to this audience. She's a radiation oncologist at Peter MacCallum Cancer Centre and a Senior Research Fellow at the University of Melbourne. She's recently stepped down as the chair of the lung subspecialty group of TROG. And for more about Fiona and her time in medicine, I'd encourage you to go back one step and listen to episode 56 in this series. Good evening to you, Keryn and Fiona.
Hi, Tim. Nice to be here. Thanks.
Hi, Tim. Great to be here.
So I'd like to start the evening by discussing patients who have thoracic malignancies. And in this case, we're going to talk mostly about non-small cell lung cancer and having brain metastases at presentation. And often these are patients that are ones that will present with symptoms or neurological deficits, although occasionally they're found asymptomatically. And I'd like to go to you first, Keryn, to talk about the role of neurosurgery in CNS metastases. How and when do you get involved with newly diagnosed patients, and what's your role?
Yeah, thanks, Tim. Absolutely. So one of the largest proportions of our patients that present with metastatic disease is with thoracic or lung cancer metastases. So oftentimes with a primary diagnosis, these patients will present with maybe just ongoing headaches or seizures or an acute deficit, so a weakness of some description. So these are the patients who will either come via their local practitioner with mild symptoms or with an acute event. So when they come in under my care, under the neurosurgery care, generally speaking, and they will often come with a CT scan or an MRI scan of their brain, which will show a lesion. The main question is, what is this lesion? Where did it come from? And what might the treatment and adjuvant treatment be for this patient? So for us, we're kind of sorting out what the actual diagnosis is so that we can get these patients to the appropriate adjuvant therapy, which in this day and age there's more and more opportunity for. So the decision-making regarding operative management of these patients is largely based on what their presentation is, if it's seizure, if it's deficit, and where the lesion actually is in the brain. And that's a team approach, and oftentimes in complex patients, we will get our oncology colleagues involved so that we can get a guesswork of what we think the diagnosis is, especially for lung cancer. They'll often have staging imaging, which also shows lesions in the lungs, and we can work out who the best people are to get tissue diagnosis. But for us, it's symptom relief, getting an appropriate tissue diagnosis so we can get them to the adjuvant therapy.
Are there presentations that are sort of particular red flags where surgery is, pretty much mandatory? What sort of situations might they be?
Yeah, absolutely. So if there's significant mass effect from a lesion that's causing the patient a significant neurological deficit, so ongoing seizures, then The other aim is obviously to reduce intracranial pressure, so that we can get these patients to a point where they're stable enough to have a diagnosis and get onto the adjuvant therapy. So we generally, we don't generally say no to most patients because the importance of getting the tissue diagnosis is key. So yeah, we usually will at least be able to get some sort of tissue diagnosis.
Are there parts of the brain that are do not fly zones, areas where operation is sort of best avoided?
Yeah, so some difficult considerations are patients who present with lesions in really eloquent areas. So anything in kind of the diencephalon, so the basal ganglia, anything in the brainstem is really tricky for us. And in that case, we need to weigh up the risk versus benefits of potentially giving that patient a further deficit, in which case, we might be making them worse for the maybe shorter amount of time that they have to live. So it's all a really individual case by case basis with the patient and the family.
And what about the patient with significant edema where their presenting deficits don't respond to steroids? Is that a case where you might try and debulk?
Yeah, absolutely. So our goals of surgery, generally speaking, is maximal safe resection. So we want to be able to address the mass effect and the pressure effect in the first instance, as well as getting tissue. And obviously that depends on the eloquence of the area. For metastases, we don't often come across metastases in areas that once we've debulked them that they have ongoing pressure effects. But it's tricky, and it's a case by case scenario.
So moving on to the role of radiation, Fiona, fortunately, I think in my experience, we're finding more and more small metastases through the increased availability of MRI and MRI staging. Let's say that we've got a patient with a known diagnosis coming to you. What are the considerations for radiation around brain metastases?
I think the first thing is to look at the whole context of the patient. Most of the time, these patients are known to us, are known to our service, and so we'll have a lot of information about their biology, their systemic options, and a sense of how functional they are and how much their level of function has changed before they've reached us. And they're all things we consider. And so I guess the classical example of this is, you have a young mutation-driven patient and they have a lot of metastases up front. And so in our setting, we have a centralized neuro radiation oncology and neurosurgery service because we have a gamma knife, and we triage people who are appropriate for gamma knife treatment and those who can be treated locally at our campuses. And that's because the gamma knife is located in the city, so patients have to often travel to have treatment there. And so we refer all our patients from our MDMs to this central multidisciplinary neuroradiation oncology/surgery meeting where they have a lot of specialist expertise in radiology and pathology as well. And usually I or the treating oncologist will be present at that meeting to give a clinical context. And then there's a discussion about, is this patient suitable for gamma knife treatment? And so say if the patient I had recently was a patient in their 30s with a mutation-driven lung cancer who'd was progressing on osimertinib and had a lot of mets. And we had a long discussion about radiotherapy. And back in the day, we would have offered this patient whole brain radiotherapy, but it's very morbid. So this patient ended up having, I think, 8 or 9 metastases treated simultaneously on the gamma knife, and then looked at their systemic therapy options. So this is an increasingly common scenario for us. And I guess at the other extreme, we have very frail older patients where really there are not a lot of options, and we have discussions about whether or not we should do whole brain radiotherapy. I think the number of patients we use whole brain radiotherapy in is getting less and less. And it's probably treatment that we actually use more frequently for patients who have leptomeningeal disease, where we don't really have other good options for managing their intracranial disease. Yeah.
Well, we we shared an interesting patient who I might describe, who was 47 when he came to me with EGFR mutant disease, and at the time, osimertinib was well known about but not available, and he was very fortunate to be able to go on to a study that was run by TROG that you were heavily involved with called OUTRUN. I bring him up because it's a sort of excellent example of collaboration that he was able to receive treatment in a clinical trial despite the COVID pandemic. And really, this trial focused on the role of stereotactic radiation up front in oncogene-driven patients, particularly EGFR mutant setting, where there's been some argument about whether or not we should offer radiation up front or if we should rely on drug therapies. How has that changed your approach to oncogene-driven cancer patients when there are effective systemic therapies? Are you more likely to give radiation, or are you more circumspect now?
Look, I think the evidence in this space is evolving, and it depends on what oncogenic driver we're talking about and how effective the TKI is. I feel like in the case of classical EGFR mutations, where we now have a very effective third-generation TKI and osimertinib with very good intracranial penetration, we've seen that not just from our own study, but also from the LAURA trial, from the FLORA studies, the Bloom study, then we needed to know whether or not we could delay radiotherapy in those patients. And that's one reason why we did the trial. And, our initial findings, which were presented last year at World Lung, show that certainly in the majority of patients, you can emit upfront SRS, probably with the exception of patients with large brain mets who seem to do worse. So the bigger the brain met, the harder it is to get control. And those patients, I think it's useful to consider selective SRS to those patients. And I focus on saying SRS because I think the evidence is more and more that SRS is very appropriate treatment, even for patients with large numbers of metastases.
Is there a size of metastasis where you would say, hey, I'd love to give stereotactic radiation, but I would like the surgeons to debulk this to make my field smaller? Where's that cut off?
There is a size, but I can't tell you that because we've just submitted that endpoint for publication. So I'm not going to share that information with you until it's published.
We'll keep our eye out for the Journal of Significant Results publication coming out in the near future, and we'd love for you to share that on social media when it's available.
Oh yeah, for sure. And hopefully it'll be all over social media. Radiation oncologists love nothing more than the ambivalent negative study because we rejoice in those studies because they make our lives so much more interesting.
Keryn, do you get radiation oncologists asking you to debulk sizable lesions? Is that a common request?
Yes, it is common because oftentimes they'll come via us first. So generally speaking, if a patient has a known disease and it's come via an MDM or via a known oncologist, then it's a little bit different. But we're always very happy to engage in discussions with the home team and the patient to aim for a surgery that might be able to decrease the tumour load for that patient. And it's all based on their clinical presentation, obviously, and the area that metastasis is in. Debulking of metastatic disease can sometimes be tricky in that with maximal safe resection, you have less of a chance of postoperative bleeding. Leaving some tumour behind can sometimes be associated with hemorrhage in the surgical cavity. So it's always a balance of what we can achieve surgically and making sure that the patient is safe. But we're always happy to engage in that discussion.
The oncogene driver space has been really quite interesting. If we consider the two major poster childs in oncogene-driven lung cancer, the first one being anaplastic lymphoma kinase, which affects about 3 to 5% of our patient population. And we learnt very early on in the piece that our first-generation therapies like crizotinib provided excellent systemic control, but really did not protect the central nervous system. And the availability of second and now third-generation drugs in this space has been a real sea change. The data for lorlatinib showing median progression-free survivals beyond 5 years. But I think what's been more interesting is the EGFR mutation space. And we've been very blessed to have third-generation inhibitors available like osimertinib. And the move to be able to get patients out of our infusion suites has been welcomed by both oncologists and patients. But I think what has been really interesting is data from sets like FLAURA2 showing that, in fact, patients with poor prognostic markers, including CNS disease, seem to get a significant survival benefit from having good old-fashioned systemic chemotherapy added back into their mix of treatment. So that's been a paradigm shift, certainly in my practice, seeing young patients and moving back towards giving TKIs and chemotherapy in some oncogene populations. The data around immunotherapy very similarly shows interesting results with reasonably high rates of intracranial response to immunotherapy in traditional populations where immunotherapy may work, such as patients with tobacco-driven lung cancers and higher PD-L1 expressions. And similarly, in the same way that this has revolutionized systemic therapy results, it's also had the same effect on intracranial disease control and having some of our patients survive a very long time with intracranial metastatic disease. And what these longer survivals mean is that we're now confronted with some of the morbidities of long-term survival. And coming back to the patient that Fiona and I shared on the Outrun study, he was randomized to receive upfront systemic therapy and radiotherapy. And about 15 months after the commencement of treatment, he had progressive CNS lesions. And so now we move into a discussion of management of refractory lesions. Keryn, when would you consider resecting a CNS metastasis in someone who's had a longer history of disease?
Yeah, that's really tricky. As you say, Tim, people are living longer with this disease because of the availability to the treatment. So I guess for us, once again, it's going back to that MDM discussion and working out the clinical standing of the patient. If there are lesions that are resectable with minimal morbidity and it's going to offer that patient the opportunity for further adjuvant therapy, then I think that's a very reasonable thing to do. There used to be a trend to not want to do further operative intervention on patients who'd had a lot of radiotherapy due to wound healing concerns, but we found that that hasn't been borne out in the literature, and it hasn't certainly been borne out in reoperations that we've done. So we're very happy to go back, and once again, it's a case by case discussion with the MDM team.
Fiona, is everything that grows in the brain on an MRI malignant?
Is that a leading question? Because the answer is necrosis is very difficult to diagnose.
Yeah,
and it's often and even in it, like this patient went through our neuro oncology NDM several times. I remember the discussion, and I think even then it's difficult. You really have to watch a patient over a long period of time and track the trajectory of how it appears on MR.
For the listeners who are not familiar, what is radionecrosis?
So it's unfortunately relatively common side effect where you get death of the brain, which is next or around the tumor within the radiated field, which is not what we desire, because you essentially have a damaged area of normal brain, which then causes lots of synthesis problems.
And how does radionecrosis present? How do we differentiate it from tumor?
Well, that's part of the problem. It often presents in a way which is quite similar to recurrence. The patient has headaches, they have nausea, they present with neurological symptoms. It's in the same lesion. It's very near the lesion which was treated. So it can really look clinically like they've got a recurrence. And on MR, it's not very specific. I mean, there are sequences you can try to use to differentiate from that, but it's not very specific, and it's a difficult diagnosis to make.
So, Keryn, should we be resecting radionecrosis? Are there situations where we should consider it?
I think there's certainly situations where we should consider that, and as Fiona said, as you've said, it's really hard to differentiate between tumour progression and radiation necrosis. There's not currently any advanced imaging that can differentiate between that. There's some nuclear medicine studies or PET studies that may be more in keeping with radiation necrosis, but it's hard to see. So oftentimes, if there is recurrence and we've watched them over a significant amount of time, so a matter of months, and it's still stayed not decreased and not decreased with steroid, then the question that we ask with our oncology colleagues is what's going to be better for the patient, bevacizumab or surgical resection. And oftentimes surgical resection is, if it's in an area that's going to cause no deficit or minimal deficit, or if there's, if the patient presents with that mass effect, so there's going to be symptom relief, then surgery is really appropriate, because then we get a diagnosis. And sometimes I've had patients where that tissue diagnosis may have changed slightly, so that's helpful to drive further treatment, or it will tell us that it's radiation necrosis. So you get an answer either way and you get symptom relief. So it's certainly things that we should consider, especially with patients surviving a lot longer.
Certainly with this patient and some others, you touched on steroids and bevacizumab for symptom control. And steroids are a fix for many ills of the world and certainly make the patient feel good. And I found bevacizumab quite a useful drug. It's a drug that as medical oncologists we're generally quite familiar with. And fortunately in Australia, access has been de-restricted, so we can use it fairly freely, although access in New Zealand and elsewhere might not be so good. But I've certainly found it a useful systemic adjunct to the management of radiation necrosis. And Keryn, you've touched on an area that is really important there, where you're talking about deficits and remembering that CNS metastases have sort of fairly profound impacts on the quality of life of our patients. Around neurosurgery, what are lifestyle changes that patients have to make when they've had intracranial procedures under your care?
The main thing that a lot of patients and maybe don't realise when they've presented with a lesion that needs to be surgically resected and that decision has been made, obviously the aim is to decrease the morbidity afterwards. But sometimes patients will just have presented with headaches. And if they've had an operation, the things that we need to consider, or the things they need to consider is, can they drive a car? From a neurosurgery or craniotomy perspective, if somebody hasn't had a seizure, then we're happy to say that patients can drive after 6 weeks of having a craniotomy. And even then, that's still hard for some people who may live in very rural areas. They rely on being able to drive to be able to get to their appointments. So that's certainly a consideration that has to be made. So when you go back to somebody who has had this disease and you're talking about radiation necrosis and they may be minimally symptomatic, having a craniotomy and restricting their lifestyle is something that we really need to take into consideration in that decision-making process as well.
And I'd highlight for practitioners that there are Australian fitness to drive guidelines that you can refer to in the event that you're caring for a patient who has a neurological deficit, so that you can provide them advice on their safety and fitness to drive. And certainly relying on your multidisciplinary teams, particularly allied health and social work, can be a very important component of holistic management for these patients. Fiona, in a similar way to the effects of surgery on lifestyle, are there issues that arise both in the short and long term as a consequence of stereotactic radiation that patients need to be aware of?
I mean, one reason for the switch to stereotactic is that it's much less morbid than whole brain radiotherapy. But I would say it's still very common for patients to have fatigue, to have headaches, and to have symptoms of, raised intracranial pressure, and to require short-term steroid therapy even after stereotactic. And obviously the same issues with driving and lifestyle. And usually patients come off their steroids and recover fairly quickly. And you just have to monitor them and make sure that their symptoms are really well controlled before you take them off their steroids. So it is similar. It's better, much better than whole brain. We don't get the really profound lethargy as much and fatigue in most patients. But it knocks patients around, and they need to allow for that to recover, I think, and get back to normal.
Yeah.
The patient who we've discussed before with an EGFR mutation had a transformation of his disease down the track to small cell lung cancer, which occurs in about 1 in 20 EGFR mutated patients. But I'm going to use that as a segue to talk about traditional small cell lung cancer, particularly in the setting of patients that have had traditional tobacco consumption. And historically, the available clinical trials did not make great use of MRI surveillance of the brain. And prophylactic cranial irradiation was shown in many patients with small cell lung cancer to have a survival advantage. Fiona, has the landscape changed around prophylactic cranial irradiation? When are you considering it in de novo small cell lung cancer?
So I think the landscape is changing very rapidly in that space. And it's been changing for a while, driven both by the evolution of SRS and the availability of MR. And now, of course, a very exciting progress which has been made in systemic therapies for small cell with, tarlatamab and other newer agents coming into play, which has made the decision-making very complex. So I guess the nutshell summary is that PCI has a survival benefit in limited stage small cell in patients who have good outcomes in terms of their disease control in their chest. And in younger, fitter patients, I think most radiation oncologists would still discuss PCI. But we know that PCI is morbid and that there are late neurocognitive effects. And particularly in patients over 70 or patients who are frail to start with, you can really have very significant neurocognitive decline. And that's even, I think, even though there's been progress with things like hippocampal avoidance and in some cases, using memantine, which is very commonly used in the United States, for example. So I think the short answer is most radiation oncologists would have a discussion, particularly with a younger, fitter patient. And 70 is roughly about the cutoff, depending on the fitness of the patient. The fit 75-year-old, 80-year-old is usually not that fit after concurrent chemoradiotherapy for small cell. That's one of the major issues. And there are, I would say the split, at least in my practice, is about 50-50 of patients who opt for MR surveillance versus those who opt for PCI, because some people just want the security of knowing that they're not going to have a significant risk of intracranial attacks.
So small cell lung cancer is a level of difficulty up from what we've been discussing, and I might increase the level of difficulty now. What about whole brain radiotherapy for leptomeningeal disease? When should we consider pursuing that? And are there patients perhaps where that might not be the right treatment for them?
So actually, this is a very common discussion, Tim, and it's common not just for my mutation-driven lung cancer patients, but I also treat breast. So I treat a lot of young breast cancer patients, and it's a very common problem, unfortunately, in mutation-driven patients with HER2 mutations to have progressive intracranial disease and leptomeningeal disease. And we do have discussions about whole brain radiotherapy, or more commonly, if we can, we might, for example, treat the posterior fossa if that's where most of the leptomeningeal disease is concentrated, and still treat the rest of the brain with SRS. So we do all sorts of fancy things that we can. In the context where you have to offer whole brain, there is value in considering ways to improve the impact on cognition. So I think it's very reasonable to consider hippocampal avoidance. I think it's reasonable to consider memantine. All these sorts of things are certainly being used. And you have to have a very frank discussion with the patient about what this means. Unfortunately, younger, fitter patients get a lot of intracranial disease and morbidity, but they don't tend to have extracranial progression as commonly, particularly if they've got effective therapies. And that's actually a really difficult situation. Demands a lot of sensitivity and a really frank and close discussion with the patient and their family about what that means, because that's a lot of disability to deal with in a family if that person's been a carer or the breadwinner, for example, and a lot of involvement by allied health and early involvement of palliative care as well at that stage.
I know as a medical oncologist, we have more manoeuvres in our trick bag than we used to for managing leptomeningeal disease. Certainly looking at drug dosing, drug delivery, antivascular therapy. There are even series around of using intrathecal chemotherapy in some situations, but the number of times where that would be considered would be fairly rare despite the existence of case series, and it's not something that I've done. Keryn, if I can ask a final surgical question to you. In the setting of sort of CNS-related hydrocephalus or obstruction, when would you consider a shunting procedure?
Yeah, that's a great question. And once again, it is important in patients surviving longer. If they, for example, patients with leptomeningeal who can develop CSF disorders, it's all about the quality of life for the patient. So if they're symptomatic from hydrocephalus, so from raised intracranial pressure, they're getting headaches, and they have still some adjuvant chemotherapy or further radiation therapy options, I'm always very happy to have that discussion with the patient. Having a CSF diversion or a ventricular peritoneal shunt is not a significantly morbid operation. There's not a high risk profile with that. And if that's going to give them symptom relief for their ongoing therapy, then it's very reasonable. We haven't found that I think some of the previous concerns have been shunting or putting in ventricular peritoneal shunts. There can be a higher rate of obstruction of that device. So if there's a significant tumour load in the CSF, then potentially this system has a valve associated with that. So there was a concern that could lead to obstruction and potentially need to be revised, but we don't tend to see that very often. So palliative shunting is helpful for some patients, and particularly, I know not for this group, but for the breast cancer patients who've had leptomeningeal dissemination, we do that quite often.
Keryn, did you have any other topics that you wanted to cover that we haven't covered already?
No, that's great.
Fiona, did you have anything else you want to add?
Well, actually, one of the things I'm interested in is Keryn's thoughts about neoadjuvant radiotherapy before SRS, because it seems to be a hot topic in that sort of literature and an area of interest. And I'm just wondering, the problem is the tissue diagnosis issue.
Yeah.
So what are your thoughts on that?
It's really hard. So I would love to have neoadjuvant therapy, but I guess in our institute it's tricky because a lot of the time to drive these patients into the appropriate MDMs for discussion, the teams want tissue, so they're not discussed before we get tissue. So having that discussion and having that engagement, earlier would be super helpful, I think, because as you say, it's a really hot topic. And I think that we should be moving towards thinking about that, because ultimately we're looking at trying to decrease the morbidity in patients and offer them, prompt upfront treatment. So I think that that's a landscape that we should be going into, that we should be looking more into, yeah.
I just hope that in the future, we'll be able to get diagnoses through CSF and more
absolutely. Yeah.
Fiona, what would the advantages of neoadjuvant radiation be?
Well, I think one advantage, this is an area where I am not the expert. I will say that, Neda Hegigi, who I work with, is very much the expert in this area. But one advantage is that you're often treating a smaller area, because if you have to treat a whole post-op bed, it's a much bigger volume of brain to treat. If you treat neoadjuvant radiotherapy, you can treat everything up front. It's a smaller volume. There's less, it's a less messy area to cover. So there are real technical advantages to neoadjuvant radiotherapy, and it seems to have better outcomes in terms of progression-free survival, though those trials are being done right now, which is a very exciting thing to see.
Keryn, does neoadjuvant radiation change the nature of surgery for you?
Not really the nature of surgery. So as I said, having surgery for patients who've had neoadjuvant radiation or have had radiation doesn't change wound healing. It doesn't really change the type of surgery. Patients don't tend to hemorrhage more, if we needed to still operate on them. But as Fiona has mentioned, it's all about getting a tissue diagnosis before we can offer that. And so changing that thought process around that is really important.
It's an exciting space, Tim. There's so many look at so many trials. It's very, very exciting.
Well, thank you, Keryn and Fiona, for joining me in this discussion. It's been wonderful to flesh out some of the nuances of management of CNS metastases in lung cancer. I'd like to thank the listeners as well for tuning in, and I'd like to thank Pfizer for sponsoring this podcast episode.